I was with a physician that I was coaching and training. We do individual physician coaching for those that want it or those that fall out in terms of their individual performance. There's both proactive coaching for everybody, and that's the highest yield activity. Everybody, here are the set of things that work in terms of the clinical encounter. And then there's reactive coaching, those that really struggle to be able to coach them one-on-one. We do both at Sharp. But this is one particular physician who was a provisional physician, and she was seeing a patient for a ED follow-up for diverticulitis. And I watched her and shouted her why she was seeing this patient. And she explained diverticulitis. So how would you explain diverticulitis to me? Who wants to explain diverticulitis? Everybody knows what that is. What would you say? Yeah, outpouch of the bowel, swelling, edema. Right. We're like a Ken Robbins textbook of physiology and pathology. And that's exactly what she had done. And when you're getting shadowed, you're doing the very best you can. It is a sample bias because that's the best you got. So after we finished, I asked her, I said, how do you think that went in terms of your explanation of a medical condition, the diverticulitis in particular? She self-reflected. She said, outpouchings, edema, swelling. It was pretty good. I said, do you think there's anything else the patient might want to know? She thought, edema, swelling, pouching, low residue. So do you think the patient might want to know what's going to be happening next? The natural history of the condition. She goes, oh yeah, probably. What they're supposed to do when they go home. What are the return precautions? These are the things that matter to the patient that we don't deliver. These are the measures, the proxies for, did they care about me? Medication, the name of the medication, purpose of medication, potential side effects, duration of therapy. And I'd said 20% of the time we do all these. A query of their understanding, a query of their comfort with the treatment plan. Does this sound reasonable to you? Including patients in decisions. Shared decision making is a very powerful mechanism to improve clinical quality and reduce cost out of the gate by 30%. It is the ultimate caring gesture. We have to be careful about shared decision making as patients participating in treatment decision based upon information you provide. When we're in a critical situation, if a patient comes in with a blood pressure of 190 over 120, you don't want to approach the patient and say, how would you like me to manage your high blood pressure? It's a little bit like the mechanic coming in with water leaking out of your pipe saying, how would you like me to fix your pipes? We have to articulate and communicate with confidence and clarity a recommendation based upon evidence, but including them in terms of what they want to be able to achieve. Treatment options, risk, benefits, anticipated outcomes. Recommendations based upon evidence and patient and family input. Including patients and asking patients, I have recommendations for what I think would work best, but we are absolutely a team. I want to make sure I know what you want to achieve. Try that with a patient. So, again, expression of empathy, conveying physical exam findings. Well, physical exam is a weird activity. I mean, there's no other profession where this happens. And I've shadowed and trained physicians, and I watch what physicians do and what patients do to what physicians do during the physical exam. And there's some physicians that will close their eyes, like they're napping. I have other physicians who sigh, like they're disappointed in something. I have other physicians that will do, or that's interesting. And there's no patient that really wants to be interesting. I have other physicians who have told the patient a physical finding without giving them any reference as to what it is. Oh, you have a bruit. Patients are sitting there going, I am being examined, and there's weird mannerisms and expressions that I can't really interpret happening right now with this person I don't know touching me. It is. It's a great opportunity. Patients love to get in our mind what we're looking for. I always tell patients what I'm looking for. And I always explain the normal and abnormal findings later, but I will take them through a normal physical examination. They love that. It's what people do when they care about other people. And it takes virtually no time. So we're going to take you through a clinical scenario. We're going to apply some of this stuff. Anybody want to come up here and be the physician? I'll be the patient. No? We'll do a group effort. How's that? Yeah. I won't pick a volunteer. So here we go. Here's a clinical scenario. So we're going to see the patient in the ED. So, you go down to the ED sometimes. It's front door to the hospital. 47-year-old male comes to the ED with chest pain, cough, shortness of breath, travels as a consultant. This was not me, by the way. I said, that kind of sounds like me. But here with his wife, workup reveals a PE, clinically stable. You're called to admit the patient. What do you do? Take me through it. You walk in. I'm going to give you the knock, knock. Okay? Knock, knock. There's a curtain. There's no door, so you knock on the wall next to it. Knock, knock. What's that? Good. Excellent. See, it's a learning organization. So yes, grab a chair. Do you guys have chairs in your EDs in your hospital rooms where you can sit? Not always? Your CEO's here. That's awesome. There we go. But if you don't properly use that biomechanically, you can use that chair in sitting down to say, wow, this is, my first moments of my impression are going to make an amazing difference on this. But again, if you sit on the chair and spin around and face the computer, that's not really what this is intended to be. So you pull up the chair, you sit down, you wash your hands, right? And of course, you walk in, wash your hands. First thing we do. Patients have got to see that. CDC guidelines, patient safety, everything. There's even one hospital now that has RF detectors on their name badge. And if you don't dispense the foam within 30 seconds of entering the room, they can tag it. Ooh, wow, that's painful. That's kind of Big Brother-esque, but talking about feedback loops in performance assessment, creating accountability to create consistency of behavior. So that's what people are doing now. Couldn't do it on our own, so we have to deploy additional behavioral levers. So anyway, so you wash your hands, you sit down, and then what do you say? What's that? Introduce yourself. Right. So what do you say? So you're a cardiologist. So cardiologist is going to admit a PE patient. That's okay. So let's just say you're a hospitalist. Say, aren't you glad you said something now? So introduce yourself to me. I'm a 47-year-old there with my wife sitting there. You're part of the hospitalist team. You've got a 12, you guys do 8 12-hour shifts? What do you guys do?
11 in a day.
Okay. 11?
Days to 11 hours.
Okay, 11 hours. Okay, so you're in your 9th hour, and it's, how many admissions you get in a typical 11 hour? If you're the admit doc.
Usually 3 to 4, but we don't have like a designated admit doc.
Okay. Okay. So it's a modest workload. You're not frantically overrun. It sounds like it's a reasonable pace. You got a mix of rounding and admitting, right?
Yeah.
So I'm sitting there, and you introduce yourself to the hospital. So let's take a hospitalist. So what do you say to me?
I say hi, I'm Dr. Rachel Hart, and I know who they're given. I say my job is kind of taking over for your Dr. So-and-so while you're in the hospital.
Okay. Good.
Then I will ask them so far, what is the ER doctor told you about, their findings and what's going on.
Good. That's fair. Good. Excellent. Any input? Any additional help? So we're all good. Let's take a look. Because we're running out of time, I'm going to take you through a checklist. Because in terms of getting things done every single time, I am obsessive about checklists. In terms of what is the bundle of behaviors that we can do every single time as standard work, as our way of doing things. It's supported by our measurements, it's supported by our code of conduct, it's supported by our training. And we run with this. So we use a checklist in terms of the things that we do. So when I coach and train a physician, When I shadow a physician, it's on my iPad. Knocked on the door, introduced self, washed hands, reference known workup and chart review. So the patient's already been there for 6 hours, had a chest CT, had 2 EKGs, had laboratory work, and a physician who comes in, and I've seen this exact scenario come in, where the patient will asking the open-ended question, what brings you in today? Really? I've already told like 6 people the exact same story, and it unravels assurance, trust, and confidence. So our ability to take with us, to review when you go in, I mean, do you not know a lot of the history when you first walk in the room? You know the chest CT, you know the vitals, you know the labs, you've gotten a brief sign-up from the ED physician perhaps, you've read the ER note, not that we complete the evaluation before we see the patient, but we know a lot, do we not? The patient wants to see that you're all over it. Not that we still want to provide an open-ended query because we don't want to propagate a wrong diagnosis. That's well demonstrated in the literature. And you probably have some M&M here where just the wrong thing was propagated because doctors were too lazy to stop and think independently themselves. Happened to my brother-in-law. I got a phone call at 2 o'clock in the morning. Chest pain, shortness of breath. Just passed out. Call 911, and I called the ED, and it was the hospital near his house. He lived about an hour from where we are, and I didn't know what was really happening. But chest pain syncope, that's of cardiac etiology until proven otherwise. I mean, it certainly could be a PE, a variety of other things it could be. But he went down the algorithm of this is cardiac ischemia. He got everything. He got a stress echo, he got labs, he got a chest CT, he got duplex, he got carotids because he lost consciousness and what they're looking for. But I don't know what but it was a big fat workup. He calls me while he's in the hospital. He said, I keep telling everybody, I've got this horrible rash and everything itches and I'm hoarse and my asthma is really acting up. He had anaphylaxis. As anybody took a history and listened to the patient, he had just taken soy and he was having an anaphylactic reaction. He was like red. And they were, so nobody stopped and paused. So that open-ended query and thinking independently, inquisitively, is not what we mean by bringing forward the known workup to date. But wash your hands, reference the known workup in the chart. So I've had a chance to review the chest CT, I've spoken with the ER doc and I've reviewed your records. Everything really looks pretty good so far. And to be able to say, gosh, phew, I'm with somebody that's all over it. Reference a primary care physician. I've worked with Dr. Spees over the last 5 years, fabulous doc. Patients always come here, they love Dr. Spees. That's how a group works. That's the dividend, that's the advantage of an integrated system, is that we're connected, we position each other well. Use an open-ended query, tell me a little bit about your chest pain. You've already known, you're not walking in, tell me what's going on, and being unaware of everything that they've been through. Paraphrase the history. And when they give you the history, use things that demonstrate an inquisitive nature. Tell me more about that. And then what happened? And then what happened? Dig. Find the history. Find the context. The history is where the diagnosis always resides. Also, there's stuff that we use. If you can't figure it out at the end of the history, then you haven't asked enough questions. And that's the great part about what we do. And paraphrase the history. Seize empathic opportunities. It may be, there's clearly can be related to the chief complaint, but there's other things that are empathic opportunities. And there is no clinical encounter in which we do have some opportunity to seize that. Explain what's going to be happening next in the course of care, explain the condition, explain treatment options. So when we diagnose the clinical encounter, and any physician who struggles with the patient encounter, it is obvious why patients say what they say about them. So individual one-on-one shadowing is a mechanism by which to help. And collective group training is another mechanism by which to improve the effort. Here is the real checklist. The first checklist is kind of the easy stuff. Here's where the magic happens. What do they do for a living? Find out what they do. Connectivity. Are you interested in what they do? Sometimes if it's a code, you know, and you're in the middle of a resuscitation, you're not going to be asking these questions. But the majority of times we can. And it's the subtleties, the texture of the human connectivity that makes them walk out and say, those people are fabulous. This is where this resides. The sense of impact of illness on their lives and an appreciation for that. That traveling consultant, what's that like to be pulled out of the work that he does, she does, for weeks on end being managing their pulmonary embolism? Their support network, their fear assessment, and the provision of hope. They're watching everything that you say and do, and we reflexively, frequently will cast a dark shadow to sort of protect ourselves. All the bad things that can happen. You try providing a medication to a patient, and it's all in how you position it. If you say, you know what, I'm going to try this medication, Elavil. Doesn't usually work. Loaded with side effects. Don't take too much. Very dangerous. You'll be constipated, you'll have dry mouth, and it may, if it does work, help your headaches 4 to 6 weeks from now. Let's make a follow-up in a couple of months and see how that goes. Thanks. Our ability to leverage a therapeutic intent is about communicating what the medication can do. Of course, we don't want to prescribe medications that don't have the prospect of helping. We have to rethink how we do things. But what we say, he who has confidence has the greatest capacity to cure. I didn't say that quite right. Do anybody know who said that? Galen, one of our founders of medicine. When a patient has confidence in you, you have the greatest capacity to cure. So, the provision of hope. So, other quick things. I'm going to finish up in 2 minutes. Whiteboards, calling patients after their clinical encounter, care identifiers, managing up. We use, we have a variation of this now. We have actually a hospitalist group that I just met has baseball cards for their hospitalists. Because attribution and identification is about who in the world actually took care of me. So they have baseball cards with a picture of them on the front and their bio on the back and their way of doing things, their sort of commitment, and they have baseball cards. It's very cool. And this is something for patients to fill out in terms of my principal questions and concerns, and the nurse can answer the majority of them, but when you go and you round up patients, you know exactly what their concerns, their worries are. They've had a chance to communicate those proactively as opposed to calling you 2 hours later. Oh yeah, by the way, the family has a couple of questions for you. This is what we do when we care about people. Calling patients, after discharge phone calls make a substantial difference in patients' perception of their care experience. We now do discharge phone calls for every single discharge patient. High-risk patients, we do it at 48 hours, 7 days, and 21 days for high comorbid conditions and congestive heart failure discharges. We've been able to reduce our CHF readmissions by about 25%. So those patients without a discharge phone call, those with a discharge phone call, those without a discharge phone call, those with a discharge phone call. What does a discharge phone call look like? I had one system that said, we're doing discharge phone calls and it's not working, it's not making care any better. Patients aren't. I said, who's doing your discharge phone calls? They said, our volunteers. Really, what do your volunteers say? Well, we just want to make sure we get to 5. So the volunteers are calling the patients after they're discharged from the hospital to ask them for a 5 on a patient satisfaction score. And that's not working. Because remember, the only 3 things really that matter are, did they listen to me, did they care about me, and am I assured that I received expert care? Those are the 3 things. That does not pull any one of those 3 levers. Anyway, so, code of conduct. We're going to close with a code of conduct. That was our commitment, our ability to manifest and express what is it that we as clinicians are going to do. Specifically, we cultivated a physician-owned, physician-written, how we treat nursing, how we treat our colleagues, how we treat our patients. It is the framework for all that we do. It is signed by every single one of our employed docs. It is the framework for our training and our development. It is the framework for our measurement, so everything is synced together. And now I've placed the code of conduct up in a place where patients can see it. And I have a 48 by 36 huge laminated poster in my exam rooms in the outpatient world with the code of conduct signed by me in the bottom, and patients walk in and they read it. What do I do knowing the patient has just read our commitment, my commitment to them, signed by me? Creating accountability and visibility of our commitment. So with that, I'm going to close. I have some other slides. We're going to get this to you in a PDF with a nice thank you note in terms of your attendance here. I'm going to close with a quick story and some of the things that I've been through in regards to doing the right thing and being the sort of physician I could be proud of. And when I first got involved with physician coaching and training, I was 35 years old. And like I said before, I'm now 48. And when I was appointed to be and lead this position, I was in a different, tough place in my life. I found medicine to be disappointing. I had accrued debt, sacrificed what I thought were the best years of my life. And the measure of my success was my ability to diagnose, treat, and cure disease. And I found that I had a tough time doing what I thought was the measure of my success through chronic disease and untreatable disease and factitious disease and functional disease and fake disease and self-limited disease. I thought, this is not what I thought it was going to be. I found patients to be annoying. And it was at that time I got a phone call, do you want to help lead this organizational change effort, the Sharp Experience? And you know, when your medical director, chairman of your board asks you to do something, it's not a question so much. And so I agreed to do it. And it's been an amazing discovery of the power of pursuing and doing the right thing and what it can do for us, for the two things that we must accomplish, fulfillment and contribution. And as I referenced, the two are linked. And it was patients who allowed me to discover the greatness of the work that we do. And I've told a lot of stories in regards to this, and I'll tell you one that made a big difference to me. It was a time when I was taking care of a police officer. And he came in to see me for dyspepsia. And he was 50 years old, an amazing guy, former SWAT officer, Iraq War veteran, just an amazing guy. And we've subsequently become very good friends. And he came in to see me with dyspepsia, and he had a little bit of dysphagia, and I said, yeah, I'm going to put you on some PPIs, but we need to get on endoscopy. And I get a call back, he gets an endoscopy in about 10 days or so, and get a call back from the gastroenterologist and says he's got an nearly obstructing esophageal CA. Game over. And he called me, I called him at home later that night. And of course, you know, they do the biopsy, waiting for the diagnosis, but it's obvious what this mass was. And I spoke with him. And, you know, he said, yeah, she said that they have some concerns, and, you know, we're just got to kind of wait and see, and kind of not what we expected, but clearly not getting it. So I said, you know, we got to wait for pathology diagnosis. And so I have him come back, and we find out in about 3 or 4 days what the results are. I had him come in to see me and I had to tell him. And he was devastated. And I went to have him go see a radiation oncologist. I mean, he was tearful and broken and mad, and how did this happen? And I sent him to see a radiation oncologist, says, we have nothing for you. And we had scanned him, we did a PET scan and a CT scan, and he had disease in his liver, in his mediastinal nodes, and nearly obstructing lesion, adenocarcinoma, and he said, get your affairs in order. And he said, no, I'm not ready yet. And I mean, it was devastating for the entire care team. But the radiation oncologist was not one that I usually use, and he said, I got to find somebody else that can help me with this. So I've got a Shankar Sundaram, who's one of our oncologists. I said, you know, I called him up and I said, this guy's he's actually a former Navy SEAL. And I said, this guy, whatever you got, whatever protocol there is, he's all in on this one. He's not, he wants to go down swinging. So I got him set up with C. Shankar Sundaram, and Shankar said, are you ready? Because I've talked to Dr. Beeson, and clearly you're expressing a desire to do everything possible to be able to manage and treat this disease. And he said, I'm all in. I'm made of steel. Nothing can stop us. Well, just give us all you got. So we took him through this brutal regimen and rescanned him, and the tumor was responding. And went through a protocol. It was, I can't tell you exactly what the protocol was, but was imaging him on a sequential basis and was really getting a response. And I knew that because I was talking to him on a regular basis on the phone. He said, you know what, after the chemo, before it sort of has its latent effects, there's a day or two where I feel good. It's like he could measure, he could almost estimate what his tumor burden was. He goes, I can feel it. It's responding. I know it, I know it, I know it. And he was responding. And then so much so to where he became surgically resectable. We said, so we have esophageal surgeon. We said, you know, so he went to this esophageal surgeon, and he went to the OR, and he described what that was like to go in the OR. Big team assembled, big operation, and they did a surgical resection, clear margins by a solid 1.5 centimeters. Unbelievable. It was like, really? And he, since that time, he has had 6 PET scans that have been totally clear. And he is active now as a Poway sheriff and speaks to physicians about the importance of provision of hope and listening to what the patient wants to achieve. He came with me to a physician academy with 400 people in the audience and spoke of this as an advocate of the importance of listening, including, partnering, advocating. And he rescued me in terms of enduring the rigors of our day, which is freaking brutal. I mean, primary care, I mean, I know what you got, I mean, it's hard. But we can sustain, we can get through, we can resurrect again if we have people like Robert. And we see and we do things in a way that allow us to become the sort of physicians that we hoped we would be. So, with that, I will close, and we have next steps that we are going to do as a result of our work here. And so I'm going to pass the baton to who? Who am I passing the baton to? And I'm going to advance the slides to the next slide. So again, we'll get these to you, but this is our code of conduct, and making and creating a code of conduct. And that's my code of conduct. And this is key learnings. Communication skills are as important as clinical skills for physician success. Respectful treatment of colleagues and nurses is as important as treatment of patients. Clinical effectiveness depends on your ability to establish trust with patients. We have a better life when we fully focus ourselves on making a difference in the lives of patients, whether you think you can or you can't. I did this last time. I had full Henry Ford quote, but it's one of my favorites. So, your next steps.
Thank you very much.
you go.
Before we...
Thank you. Thank you.
Before we get to the next steps, any questions for Dr. Beeson?
Questions, challenges, curiosities?
Great. Thank you very much.
Okay, thank you.
So these are proposed next steps for us. So this is great. Accountability and being able to be better physicians in every sense of the word are really what we aspire to. And one of the things we're thinking about is really forming a subgroup of Henry Ford hospital physicians to really talk about communication expectations and where do we think we want to go from that perspective. Our service excellence team will lead this, and Kelly Dillon, whose email is up here, will lead us through that. So if you have an interest, if this is something that hopefully has sparked something in you, this is something that you think you can be passionate about, we want to hear from you. So please email Kelly and or myself or Pat so that we can move forward. It's great that others are using baseball cards. Many of you have, all of you hopefully should have received the email so that we can go ahead and move forward with our baseball cards. So these are for our inpatient physicians, and one thing that Dr. Conway would like to do is really move forward with a drawing. So we don't do very well with our whiteboards. Our patients actually on real rounding oftentimes don't know who their physician team is or their physician team leaders are, who is the captain of the ship, if you will. So we encourage you to get your baseball cards, hand them out, and hand them out routinely, and we hope to at least start getting people to tell us about who their cards are. If we see cards or patients mention it and our families, maybe start doing something like a drawing, start in May for 4 Tiger tickets for patients. So if you're mentioned, it'll go into a drawing, and hopefully this will spark some more routine activity as far as really letting them know, our patients, who their team physicians are and who's their team leader from that perspective. And then finally, all of you have heard us talk about real rounding. We do this on a bi-weekly schedule, and select inpatient physician leaders will receive invites to join our real rounding process. We know how busy you are, especially our division heads and chairmen and other leaders, but it's so important and it's key to really get that story, and we want you to do this actually not necessarily on your floors, but throughout the house, throughout the hospital. The information that we get, the stories that our patients tell us, and our employees tell us are actually quite remarkable and heartening. We are very, very impressed with the work that we all do on a routine basis, and hopefully some of our physician leaders will join us at least quarterly from that perspective. We are a little bit over time, and I apologize for that. It's 7:10, unless anybody else has got any other questions. Thank you so much for coming. We truly appreciate it.